Hi, Mike Gibson coming to you live from SCAI 2015, and I'm here today with Jaya Chandrasekhar. Welcome, Jaya.
Thank you very much, Dr. Gibson.
Well, Jaya, you just presented the TRIAGE study. Tell us a little bit about why you did the study.
So thank you very much for this interview, and on behalf of the TRIAGE investigators and the principal investigator, who's George Dangus from Mount Sinai, we presented the results to this study. So I'll go through a little bit about the study rationale. So as we know, clopidogrel along with aspirin, so dual antiplatelet therapy with aspirin and clopidogrel is standard of care with coronary stenting. However, clopidogrel has the problem with variation with metabolic parameters as well as genetic parameters. So a proportion of patients would not respond adequately in terms of platelet inhibition. And we also know that these patients who exhibit high on treatment platelet reactivity then go on to have a greater proportion of adverse cardiovascular events, including stent thrombosis, non-fatal myocardial infarction, and perhaps even cardiovascular death. We also know that prasugrel is a more potent thienopyridine and has overcome a few of these drawbacks of clopidogrel, but comes with the cost of increased bleeding. So the question we asked with TRIAGE was whether it was possible to triage patients on the basis of not just platelet reactivity, but also the clinical risks, ischemic risks as well as bleeding risks, to select patients to improve their outcomes with optimal platelet inhibition. So the primary analysis of this study was in patients treated with clopidogrel versus patients receiving prasugrel, and the primary efficacy endpoint was a composite of death, non-fatal MI, and stent thrombosis. The safety endpoint was BARC bleeding 2, 3, or 5. And just briefly going through the methods of this study, so it was a multi-center prospective observational study, and the 3 sites involved were Mount Sinai as well as St. Francis Hospital in New York and Charité Hospital in Berlin. All the patients that were deemed eligible, and really it was a real-world study, but the main inclusion criterion was patients needed to have been on clopidogrel therapy uninterrupted for 14 days prior to coming in for PCI, whether it was elective or urgent.
Okay.
And the main exclusion was cardiogenic shock, but it was inclusive of all other patients. And so the patients that were deemed eligible.
Very important to kind of exclude those shock people, because they obviously have you have a few of those and you're going to have quite a few outcomes and it could be imbalanced, but also they have impaired absorption as well.
They do, and they do form an important group, in our trials, albeit a minority because they're always under 10%, 5 to 10%. They are very important, but I think because we set out to do this study as a pilot, we felt operators would probably exercise a lot more of their discretion rather than follow this study algorithm, which I'll talk about briefly, which might have affected results.
Sure.
But certainly in future trials, that would be an important group to look at with antiplatelet therapy.
Sure.
So all the patients that were deemed eligible were tested in the cath lab for platelet reactivity while they were on the table prior to undergoing PCI. This was done with a Verify Now assay. As you know, the results become available within minutes. And for this study, a cutoff of 230 for P2Y12 reactivity units, so greater than or equal to 230, was considered to be high on treatment platelet reactivity. And the group not meeting this was low or not high on treatment platelet reactivity. And with this result, in conjunction with ischemic and bleeding risks, in the study algorithm, physicians then selected either clopidogrel or prasugrel, and the dose of prasugrel could be 5 or 10 milligram. And just to touch upon the ischemic risks that we considered, so this was predefined, and we considered high ischemic risk as any one of the following: so PCI for acute coronary syndrome or stent thrombosis, high angiographic risk PCI, so left main or bifurcation PCI, implantation of 4 or more stents, and a stent thrombosis risk score. So this is a validated score by Dangus et al. A validated score of at least 6, so greater than or equal to 6, any one of these. And likewise for the bleeding category or high bleeding risk, it was a bleeding risk score of at least 10, and that was the Moran validated bleeding risk score for ACS.
You got a husband and wife.
We did. It was a fantastic collaboration, as well as a history of bleeding diathesis, or recent surgery. So, even with the patients with high on treatment platelet reactivity, physicians then had the opportunity to look at the ischemic risk and the bleeding risk and then select either 10 milligram or 5 milligram of prasugrel. As I say, the primary analysis was for these two categories, prasugrel versus clopidogrel. So overall, we had 318 patients enrolled, of which 90 patients received prasugrel, 228 received clopidogrel. And in terms of demographic characteristics, they were similar in most of the demographics, including age, female gender, diabetes. And this was a high-risk population for diabetes, so overall the incidence was about 45%, as well as multi-vessel disease was 73%, left main disease was 14%. So again, coming back to the demographics, so the differences existed in these characteristics. So the prasugrel group had fewer smokers, more patients with heart failure, and as expected, and in keeping with the study design, had patients with a higher BMI, no patients with prior stroke or TIA.
Sure.
And the baseline PRU values were higher for prasugrel versus clopidogrel. So it was 149 with clopidogrel and 290 in the prasugrel group. And procedurally, in terms of anticoagulation, prasugrel patients received more bivalirudin, and that might be the effect of center, because we had 3 centers, and perhaps one center used more bivalirudin than the other centers, but there was a significant difference in that respect. And in terms of results for the primary endpoint of MACE, with clopidogrel, the MACE was 3.5% versus 4.4% with prasugrel. P-value 0.7, so not significant. When we included peri-procedural MI in that composite, so peri-procedural MI within the first 3 days of PCI, the values were 9.2% with clopidogrel versus 5.6% with prasugrel. And also just looking at the secondary ischemic endpoints.
Was that number, did that trend to be significant?
No,
or?
so again, the p-value was, not less than 0.10 even.
Yeah, I see.
But again, patient numbers were small.
Small numbers.
So with stent thrombosis, only one patient had a stent thrombosis event, and that was in the clopidogrel arm. And with non-fatal MI, even numerically, the values were half. Of course, not significant, but it was 1.1% with prasugrel, 2.2% with clopidogrel. So coming to bleeding, so the study safety endpoint was BARC bleeding 2, 3, or 5, and the values were 7.9% with clopidogrel, 5.6% with prasugrel, not significantly different, and all the other secondary endpoints as well were numerically higher, but not significantly so with clopidogrel. So importantly, we also looked at any BARC bleeding, because we know that nuisance bleeding has become an important thing with hospitalization and morbidity, and the values were 14% with clopidogrel and 8.9% with prasugrel. So that's interesting and something to watch out for as well in real-world studies of clopidogrel and prasugrel use. For a secondary analysis, we looked at the differences for the primary MACE endpoint by PRU cut points as well. So we took 230 as well as 208. And with a cut point of 230, the MACE values were 2.8% in the low group, 5.7% in the high group, p-value 0.2. With 208, there was a slightly more significant trend. I don't think you can call it a significant trend, but a higher trend for benefit with the low PRU group. So it was 2.2 versus 6, and the p-value was 0.08. No difference in bleeding, as can be expected. So to conclude with this study, we think what we'd like to say is when using this predefined study algorithm encompassing ischemic risks, bleeding risks, as well as platelet reactivity, we found that patients with high on-treatment platelet reactivity receiving prasugrel did just as well as patients primarily with low on-treatment platelet reactivity continuing on clopidogrel therapy. And importantly, there was no increase in bleeding with
numerically
prasugrel.
it was lower with prasugrel, the opposite of what you might expected, but somehow clinicians were choosing the right patients and the right doses for those patients.
Yeah, and this particular algorithm that we used helped in not increasing bleeding. So that would be one of the most important implications for future practice. that we are selecting patients well for prasugrel. And another thing is, I don't think we quite know what the perfect cut point is with PRU in terms of risk prognostication and selection of thienopyridine. So we've looked at, some studies have looked at an ACS population, the others are a mixed bag. This one was a higher risk mixed population, but I don't think we know exactly. And we know that.
Well, could it be that there are multiple cut points? Maybe a STEMI patient has a different threshold than an NSTEMI, and different than UA, different than stable,
yes.
Depending on how angry and activated the platelet is in those scenarios.
Exactly. And your peri-procedural platelet reactivity and therefore risks associated would be different, therefore. In a STEMI and other population. Interestingly, there's been a few studies looking at predictors of high on-treatment platelet reactivity, and diabetes is a big one.
Absolutely, which, by the way, is where some of the novel drugs do quite well, like prasugrel.
Prasugrel does well, and perhaps it's for this reason. CKD is another group. So I know, Moran, Baber et al. Conducted a small study at Mount Sinai where they looked at platelet reactivity in diabetes and CKD, and then they found that the incidence of high on-treatment platelet reactivity goes up. So diabetes was around 40% incidence overall, CKD was 50%, and a combination of both was around 75%. So that's an important one to look at, and further studies should focus on that. And the final thing would be whether a randomized investigation of an algorithm encompassing all these features that we talked about would show us some good outcomes.
Do you guys have anything planned in that regard?
Not yet, but we certainly will be thinking about it. I mean, this study had a few limitations: the observational design, low enrollment size overall, and the fact that the algorithm was unvalidated. So those things will need looking into.
I think Gravitas and some of the other studies really didn't show a benefit to kind of adjusting treatment, but some of that may have been the risk of the patients was so low, like trigger PCI. There were 5 events. You can't really show, a benefit when you have so few events. So I think in the future you've got to really identify people at high risk of events where altering, the dosing and the algorithm may make a big difference. Great. Well, congratulations. Good work.
Thank you so much.
Great study. Always good to see a young person doing such wonderful work.
Thank you. I'm encouraged by all the work that's already been done. So,
well, excellent addition to the literature. And thanks to all of you for joining us here today live from SCAI 2015.